My name is Brian Fisher. I'm a GP in South East London, and I've been sharing records with patients since about 1984. And I began because I took my daughter, who was about 6 months old, to our GP, and the GP handed me her notes. And I thought it was just a fantastic idea, and we instituted it in our practice as routine. So people would come in and they'd be given their records at reception, and they would sit often for quite some time in the waiting room and be able to read them. And when we became electronic, that is, when paper records became increasingly irrelevant to day-to-day work, we realized we had to do something different. So we have now made it possible for all EMIS practices, that is 60% of practices in the UK, to offer their patients free, secure online access to their GP record. And that is now available to patients across the UK, not just in England, but across the UK. So record access in a surgery has variable effects on different people. So actually probably the most impact in primary care is on reception, who have to register people and who have to make sure that people understand what record access is about. For the other members of the surgery, particularly nurses and doctors, once the initial decision is made and there are some clear decisions made around particular aspects. What are you going to do about children? What are you going to do about people with psychiatric problems, for instance? Once those are clear for the practice as a whole, then actually record access becomes an integral part of care. And after a little while, pretty much every clinician finds that this just becomes routine. It does not impact very much on your daily life at all, and if anything, it probably makes life a little bit easier, because you know that, for instance, the advice you're giving patients, if you write it in the records, then the chances are they can read it. What we have is good evidence, for instance, that people come away from surgery not really remembering or maybe not even understanding the advice and information that clinicians have given them. And we also know from patients that they go home and they read it. So they see the advice you've given in black and white, and they tell us that they're much more likely to follow that through, partly because they've seen it, but also because they understand it better. It is clearer to them why you've suggested it and why they should do it. So on the whole, nurses have found this very straightforward to use. People often ask, do we have to write things in a different way? And the advice in general is that if you can make it clearer to patients by writing in more lay type language, then by all means do so. But it is essential to remember that the record is a technical document. It's a document for clinicians to converse with each other and to know what's going on. So dumbing down the record is not what this is about. If you can write stroke instead of CVA or heart attack instead of MI, by all means do so. You don't lose any information by doing that. But if you find that you want to make something clearer and you end up losing information, that is not advisable. The patient has to understand it's a technical document, and if you can't avoid using technicalities, then that's something they have to grasp. Don't forget that in the system that is currently available to 60% of the UK, there are actually links between the read codes, that is the coded data in the record, and information. So for instance, if a patient sees the word asthma, then they can click on that and they will be taken through to patient information leaflets specifically around asthma. So there is an automatic advice and guidance process that is integral to the record. And people can understand a great deal more of what they read by following those information links. So you can feel confident that if you read code something, if you make it clear and code it in the record, then the patient will be able to understand it and will be able to follow the logic of what you're doing.